So surgical site infections are defined as infections occurring up to 30 days after surgery and includes infection either in the incision or deep tissues at the operation site. Despite improvements in prevention, SSIs remain a significant clinical problem, and in fact, as cesarean section rates have increased globally during the past 3 decades, so did surgical site infections. Good afternoon, doctors. I am El Carl Marie Jacobo, and together with Dr. Angie Acampo, we will be presenting an ounce of prevention for a gram of cure, preventing and managing surgical site infections. Our objectives for this session are to one, to present the patient's history and physical examination, to discuss methods of preventing surgical site infection, and to discuss the management goals of surgical site infection. Here we present an actual case, patient LJ, a 26 years old, Gravida 2, Para 1, 1001, single Roman Catholic from Holy Spirit, Quezon City, who works as a vendor who came in for labor pains. The patient came in for her first consult in our institution, presenting with perceived contractions associated with labor pains, with good fetal movement, no watery or blood discharge. The patient has had her prenatal checkups at the local health center for a total of 2 visits. Of note, during the third trimester, the patient was diagnosed with GDM and the patient was advised to do CBG monitoring, but was, however, non-compliant. She is a Gravida 2 Para 1. She is a Gravida 2 Para 1 1001 with an intrauterine pregnancy at the time of consult at 39 and 4/7 weeks age of gestation. Her past medical history, family history, personal and social history are all unremarkable. She arrived ambulatory, not in cardiorespiratory distress, with stable vital signs with a BP of 110/80, non-tachycardic, non-tachypnic, afebrile with clear breath sounds, and no bipedal edema. Her abdomen was globular, with Lupolt's maneuver showing a cephalic fetus with a fundic height of 37 centimeters with an estimated fetal weight of 3,875 grams by Johnson's rule. There was good fetal heart tones at 150 beats per minute. On internal examination, her cervix was 2 centimeters dilated, 50% effaced, encephalic presentation with intact bag of waters at station -2. Baseline laboratories revealed a hemoglobin of 126, hematocrit of 35, platelet of 294, with an elevated 75 grams OGTT. Hence, our admitting diagnosis for this patient was a Gravida 2 Para 1, 1001, pregnancy uterine 39 and 4/7 weeks age of gestation, cephalic in labor, gestational diabetes mellitus, unknown control. The patient underwent 18 hours of labor and subsequently underwent low transverse cesarean section for arrest in cervical dilation secondary to fetal-pelvic disproportion. On post-operative day 1, the patient had clear adequate urine output. She had flatus but no bowel movements with no subjective complaints, stable vital signs, and IV antibiotics were continued. Her repeat hemoglobin and hematocrit revealed a hemoglobin of 123 from 126 and a hematocrit of 0.36 from 0.37. On post-operative day 2, the patient now had flatus and bowel movements, and a change of dressing was done, which revealed a dry, well-coaptated wound. Her IV antibiotics were now shifted to oral antibiotics. On post-operative day 3, the patient remained stable and her oral antibiotics were continued. On post-operative day 4, on daily CO change of dressing, it still revealed a dry, well-coaptated wound. However, on post-operative day 3, on change of dressing, a 0.5 sub-centimeter superficial defect in the lower third of the incision site with no discharge expressed from the abdominal wound was found. The edges were dry and non-erythematous with a 1 by 1 centimeter induration on the upper third area of the incision site. Here is the actual picture of our patient. At this time, our diagnosis is Gravidad 2, Para 2, 2002, pregnancy uterine, delivered cephalic term live birth via low transverse cesarean section for arrest and cervical dilatation, secondary to fetopelvic disproportion under spinal anesthesia, gestational diabetes mellitus diet controlled, post-operative day 8, surgical site infection. So I will brief through what surgical site infection is, but later Dr. Acampo will be explaining it. Surgical site infection are infections of the incision, organ, or space that occurs within the 30 days of the operative procedure. So for this patient, we were um, entertaining that this is a superficial surgical site infection. So Dr. Acampo will be explaining this later on. So now, our working diagnosis is a gravidad 2 para 2 2002, pregnancy uterine delivered cephalic term live birth via low transverse cesarean section for arrest in cervical dilatation, secondary to fetopelvic disproportion, GDM diet controlled, post-operative day 8, superficial surgical site infection. So these are the problems that we have um, seen in our patient. She has gestational diabetes mellitus. So our goals is for adequate glycemic control with management of DM diet and continuous CBG monitoring. Since she just underwent low transverse cesarean section, our goals is for guided spacing and planned conception through family planning and mainly surgical site infection, hence prevention and management of further progression through workups and antibiotic coverage.
Dati, may gong siya nga dyan, napansin ko.
Sorry. For the surgical site infection, so surgical site infection or SSI is defined as an infection occurring within 30 days operatively in one of three locations. So number one is superficial at the incision site, two, deep at incision site, and three, in other organs or spaces opened or manipulated during an operation. Next, we'll be tackling the classification of the surgical site infection. So first is the superficial incisional SSI, where it is seen, the level of the involvement of the infection is seen at the skin or at the subcutaneous tissue, plus with at least one of the following. One is purulent discharge with or without laboratory confirmation from the superficial incision. Two, positive culture and sensitivity result from aseptically obtained superficial incision tissue or fluid specimen. Or three, at least one of the following signs and symptoms: pain or tenderness, localized swelling, redness, or heat and superficial incision being deliberately opened by the surgeon unless the incision is culture negative. For the deep incisional SSI, the level of involvement of the infection is at the fascia and at the muscles, plus at least one of the following. One is a purulent drainage from the deep incision but not from the organ or space component of the surgical site. Two, a deep incision which spontaneously dehisces or is deliberately opened by a surgeon when the patient has at least one of the following signs and symptoms: fever of greater than 38 degrees Celsius, localized pain, or tenderness unless the incision is culture negative. Three is an abscess or other evidence of infection involving the deep incision being found on direct examination during the operation or by histopathologic or radiologic examination. Number three is the organ or space SSI, which is seen at any part of the anatomy other than the incision that was opened or manipulated during an operation, plus at least one of the following: purulent discharge from a drain that is placed through a stab wound into the organ or space. Two would be organisms isolated from aseptically obtained culture of fluid or tissue in the organ or space. And third, an abscess or other evidence of infection involving the organ or space. For the causes and risk factors, the fundamental precursor of the surgical site infection are the microbiologic contamination from endogenous skin and vaginal flora. The usual microorganism may come from the following: our skin, the vagina, and the endocervix. SSIs are usually polymicrobial, and the risk of infection may be affected by the following: the condition of the patient, such as the age, such as if the patient has diabetes mellitus, as in our case, and obesity, increased concentration and virulence of the contaminating bacteria, correct usage of antibiotic prophylaxis, duration of the procedure, the use of blood products, type of materials used for wound closure, and extensive surgeries such as lymph node dissection, splenectomy, bowel resection, or pelvic exenteration for gynecologic malignancies increase the risk of deep SSI and organ space. The following risk factors are also contributing to the surgical site infection. Number one would be the BMI of greater than 30, subcutaneous depth of greater than 2 centimeters, diabetes mellitus with serum glucose level of greater than 150 milligram per deciliter, and hemoglobin HbA1c of greater than 6.5%. Anemia, malnutrition, smoking, and corticosteroid use are other risk factors that can be modified prior to the contemplated procedure. Um, One of the non-modifiable risk factors are the cerebrovascular accident and increased age. In
Okay,
diagnosing, sorry,
sorry. Okay, so now we will move on to the discussion part. Since our title is an ounce of prevention for a gram of cure, we will now move on to the discussion on the prevention of surgical site infections. So this one I got from Teline's Operative Gynecology. This is a table on the best surgical practice techniques to reduce SSI risk. It divided it into three timings: the preoperative, intraoperative, and postoperative. So in the preoperative part of preparing the patient for surgery, it includes assessment and optimization of patients' risk factors for surgery, which includes the type of surgery, glycemic control, management of obesity, MRSA status, immune status, and smoking cessation. I will be discussing all of this one by one later. So in the intraoperative part, you give your appropriate antimicrobial prophylaxis, you minimize your operative time duration, make sure that the patient has normothermia with hemostasis, and post-operatively, there should be correction of anemia, glycemic control, and then if you have SSI cases, you do a systematic review of all your SSI cases in your department or on an institutional level. This is to improve your SSI rates. So first, we will tackle on patient-level risk factors. This includes preparation of the patient, glycemic control, management of obesity, and smoking cessation. So aside from the recommendations from Tilines, I also included recommendations from the Center of Disease Control or CDC in their paper Guideline for Prevention of SSIs in 2017, which addresses new and updated strategies for the prevention of SSIs. And I will be also including the one in 1999, the recommendations for prevention of surgical site infection, since CDC, in its latest recommendations in 2020, they have recognized that many of the recommendations in this 1999 output remains important and remains an infection control standard for surgical site infection prevention. Okay, so for the preparation of the patient, so whenever possible, we need to identify and treat all infections remote to the surgical site before elective operations, and we need to postpone elective operations on patients with remote site infections until the infection has resolved. Another is, we do not remove hair preoperatively unless the hair is at or around the incision site and will interfere with the operation. And if it is necessary to remove the hair, we only remove it immediately before the operation, and we use clippers instead of razors. Next, glycemic control. Remember, in our index case, our patient actually has GDM in which the control is unknown. So why is glycemic control important? Impaired wound healing is a frequent and severe problem in patients with uncontrolled glycemic levels, yet little is actually known about the underlying pathomechanisms. In a study done by Sparshikov It showed that the exposure to high glucose level is associated with the changes in cellular morphology, wherein there is decreased proliferation and there is actually abnormal differentiation of keratinocytes. This reveals a mechanism by which hyperglycemia affects wound healing. In histological analysis, it was actually shown that there was severe infiltration of inflammatory cells, and there were many bacterial masses in the remaining or slight fibrosis on the crust tissue. This is the reason for the delay of crust formation and the regeneration of the epithelium. So next, obesity. So how do we manage obesity? Obesity is associated with increased SSI risk. So when prophylactic perioperative antibiotics are selected, obese patients may actually require increased antibiotic dosage. So for example, with patients with a BMI greater than 35, they are given IV cefazolin. Okay, so they have significantly lower serum and adipose tissue levels compared to non-obese patients. Therefore, the 2-gram dose is recommended for patients weighing less than 120 kilograms, while those greater than 120 kilograms, they might require a dosing of 3 grams. So next is smoking cessation. Smoking has actually been shown to increase the risk of post-operative wound complications. Aside from the fact that our pregnant women should actually not be smoking, in terms of our gynecologic cases, patients should be counseled about smoking cessation and should be advised to quit smoking several weeks prior to surgery. In a study, among smokers, 12% develop an SSI compared to 4% in those subjects who quit smoking at least 4 weeks before surgery, hence a decreased risk of SSI development. Why? Because nicotine is a vasoconstrictor, thus reducing nutritional blood flow to the skin, resulting in tissue ischemia and impaired healing of injured tissues. It also actually increases platelet adhesiveness, raising the risk for thrombotic microvascular occlusion and tissue ischemia. Okay, so now we move on to procedure level risk factors. This will be the ones that I will be tackling on. This one are actually when you do the surgery itself now. So first, skin preparation at home. So in other institutions, the patient are actually instructed to perform a preoperative chlorhexidine shower at home or at ward prior to scheduled surgery, or a full body shower or bath with antiseptic agents upon admission. This is because our skin is actually not sterile. So scrubbing before surgery plays an important part in reducing the risk for infection. This can reduce the number of microorganisms on our skin, particularly on the to-be incision site. So now for the skin preparation in the operating room. So in addition to abdominal skin preparation, we actually do vaginal and perineal preparations in both our OB and gynae cases. This has been recommended since it has shown a decrease in SSIs. What is important to note is our perioperative perinatal preparations and the abdominal skin preparation should be accomplished with separate kits and applications, even so if the antiseptic product used is the same. So important then that you change your gloves after your vaginal preparation. When you do your abdominal skin preparation, you actually need to change your gloves. So next is perioperative antibiotics. So antibiotic prophylaxis functions by augmenting natural immunity, but it has actually a narrow window of opportunity. Hence, the timing of our perioperative antimicrobial prophylaxis administration is of critical importance. So when do we give it? The administration should ideally occur within 60 minutes of the skin incision and not later than 15 minutes prior to skin incision. Why? This allows for adequate serum and tissue concentration to be present at the time of skin incision itself. So, one question here. When should additional antibiotic doses be administered intraoperatively? So during surgery, antimicrobial prophylaxis should be redosed in the setting of one, excessive intraoperative blood loss, say more than 1,500 cc, or prolonged operative time more than 4 hours. Say, for example, cefazoline. It has a half-life of 1.8 hours. So, a second dose should be administered if the surgical time is approaching 4 hours. Also, surgical blood loss has been correlated with tissue cefazoline concentration. And so, when you have a blood loss greater than 1,500 ml, the tissue antibiotic concentrations is actually significantly declined. Okay, next, normothermia. Hypothermia increases vasoconstriction. This leads to decreased tissue oxygenation and impaired local immune function. In a study by Kurz et al., it demonstrated that SSI rate decreased from 19% to 16% when the patient's core temperature is maintained at more than 36.5. What about supplemental oxygenation? So, studies have shown that perioperative hyperoxygenation does not reduce SSI, although the most important defense against SSI is actually oxidative killing by neutrophils and molecular oxygen in the substrate of the process. So actually the easiest way to increase tissue oxygenation is only to increase inspired oxygen. However, no RCTs or meta-analyses have supported this. So another is duration of surgery. This one is an important risk factor for SSI. So the association between extended operative time and SSI typically remains statistically significant. So the likelihood of SSI is increased with increasing time increments. Say for example, um, if you if your mean operative time is 15 minutes longer than the usual mean operative time for a specific surgery, your risk of SSI is increased by 13%. Say you are prolonged by 30 minutes. Now your risk for SSI is increased by 17%. And say your total operative time is increased by 1 hour. Now your SSI risk is increased by 37%. So on the average, across various procedures, the mean operative time was approximately 30 minutes longer in patients who developed SSI compared to those patients who developed without. Now we go to the abdominal closure protocol. So particular attention should be paid to the type of abdominal closure that you choose. So since this may impact SSI risk. So the method of skin closure may have a role in preventing the development of SSI. It has been found that compared with interrupted sutures, continuous sutures can provide a better seal, preventing the exogenous bacterial invasion of the surgical wound. However, the continuous tightly pulled suture can actually also strangulate the wound edges. So what then is the role of wound irrigation? So there are some surgeons who opt to do saline or povidone iodine solution wound irrigation to prevent surgical infection. So is there really a studies to studies regarding this? So here, there are insufficient data to determine the role of saline or povidone irrigation of incisional wounds before closure to prevent SSI. Actually, intraoperative wound irrigation, this one refers to the flow of a solution across the surface of an open wound. It is actually widely practiced. So among its benefits, the wound irrigation is actually intended to physically remove foreign material, cellular debris, surface bacteria, and body fluids, and to delete possible contamination, and to function as a local antibacterial agent when an antiseptic or antibiotic agent is used. So when you do wind irrigation, it actually needs to be vigorous enough to perform the above goal that I mentioned earlier, but gentle enough to avoid further tissue trauma or passage of bacteria and foreign material deeper into the wound. So, what is the role of delayed skin closure? So, delayed primary skin closure may reduce the incidence of SSI. This is a consideration in those mostly sa gynae cases siya when we are taking into consideration contaminated abdominal surgeries in high-risk patients. So this one, I got this from Tillins. They called it the perioperative bundle to reduce SSI. It consists of 10 interventions designed to reduce SSI after gynecologic cancer surgery. So usually sa gyne-onco cases natin. So I'll just breeze through it. It says patient education, the use of chlorhexidine shower prior to surgery, the washing of the abdomen with chlorhexidine in the morning again of the surgery, and then antibiotic administration within an hour of skin incision, then your skin preparation, and then your dosing of your antibiotics. Here of note, sterile closing tray. So not really popular here in the Philippines, but sa abroad, when their closing tray, the one for your closing of your abdominal incision is actually open, nearing na pag nagko-close na sila ng surgery nila. And then stop glove change for fascia and skin closure, dressing removal after 24 to 48 hours in hospital, discharge with chlorhexidine shower again. So, similar lang siya sa usual practice natin, but mas ano lang, mas madami lang silang ginagawa. Usually sa gyne-onco cases kasi parang dirty surgery siya. Okay, so very simple pero plays a very important role in preventing SSI is our surgical attire and drape. So we must wear a surgical mask that fully covers the mouth and the nose when entering the OR if an operation is about to begin or underway, or if sterile instruments are exposed. So the mask must be worn throughout the operation. Number two, we should wear a new disposable or hospital laundered head covering for each case when entering the OR, and ensure it fully covers all hair on the head and all facial hair that is not covered by the surgical mask. And then number three, wear sterile gloves if serving as a member of the scrub surgical team, and and this sterile glove must be put on after donning our surgical sterile gown. And then lastly, we change our scrub suits that are visibly soiled, contaminated, and are penetrated by blood and or other potentially infectious materials. So that's it for the prevention.
Next, we'll discuss the diagnosis of the surgical site infection. For the diagnosis, the initial recommended diagnostic tests are the complete blood count and wound discharge, gram stain, and culture studies. Since the clinical manifestations of the surgical site infections may not be apparent at all times, a CBC must be ordered because leukocytosis may be a sign of infection. The management of SSIs is increasingly relying on wound cultures as part of clinical assessment to guide the choice of antibiotic. So next is the CRP or the C-reactive protein. For early detection of post-operative infections, the CRP may be useful because the CRP is an acute phase reactant and is a marker of general tissue damage and inflammation. The CRP is superior to the white blood cell or the WBC count and erythrocyte sedimentation rate or the ESR in detecting acute inflammation because it activates sooner and decreases more rapidly when inflammation subsides. Obtaining a preoperative CRP level is more important in order to rule out pre-existing infection. Next would be the ultrasonography or the ultrasound. It can be done when suspecting an abscess formation. Ultrasound is a non-invasive, readily available test and can be performed as a bedside ancillary procedure. It is the forefront diagnostic imaging examination in cases of suspected organ or deep pelvic cellulitis or abscess. Um, Depending on the clinical presentation, the following examinations may also be performed: the urinalysis, the chest X-ray, coagulation profile or coagulation parameters. The blood culture can be done in order to rule out a urinary tract infection, pneumonia, disseminated intravascular coagulopathy, and septicemia. For the management, the following can be done in treating surgical site infections. Number one is a removal of a sufficient number of staples or sutures around the infected area to allow the assessment of the subcutaneous tissues and fascia. Number two, the fascia should be probed to assess its integrity. Then, the subcutaneous tissue should be examined and irrigated and the vitalized areas debrided. Number four, drainage of the purulent discharge is necessary to clean and remove the dead tissue that will help decrease the environmental pH and enhance the effect and penetration of antibiotic to the target areas. Fifth would be the antibiotic therapy that is indicated for deep wound infections. Unless directed by wound cultures or unique patient circumstances, antibiotic therapy should be targeted against the expected pathogens as determined by the surveillance data. The most common pathogens found in the surgical site infections after obstetric and gynecologic surgeries are the following: the gram-negative bacilli, enterococci, GBS, pneumococcus cellulitis. The following can be given. First would be the amoxicillin or the co-amoxiclav per RM twice a day, ciprofloxacin 500 mg per RM twice a day, metronidazole 500 mg per RM twice a day, trimethoprim sulfamethoxazole per RM twice a day, and metronidazole 500 mg per RM twice a day. Next for the pelvic abscess, deep and organ infections, IV antibiotics in combination of this can be given to treat this type of infection. Clindamycin 900 mg intravenous every 8 hours or metronidazole 500 mg intravenous every 8 hours plus penicillin 5 million units every 6 hours or ampicillin 2 grams every 6 hours plus gentamicin 5 milligram per kilogram ideal body weight every 24 hours. Single agent treatment can also be given by using extended spectrum cephalosporins such as cefoxitin, cefotetan, ceftriaxone, cefotaxime, and ceftizoxime. Extended spectrum penicillin with beta-lactamase inhibitors can also be given such as piperacillin tazobactam and ticarcillin clavulanate. And carbapenem such as ertapenem and meropenem may also be given. Parenteral antibiotics should be continued until the patient is afebrile for 24 to 48 hours. The choice of step-down therapy is based on the results of the culture and sensitivity studies if available.
Okay, so our take home for this conference is to SSIs are considered to reflect the quality of care as they are potentially preventable complications directly linked to surgery. And SSIs remain a leading cause of hospital morbidity and increasing overall length of stay. Hence, our primary management is actually prevention through good surgical techniques and patient optimization through several evidence-based interventions possible, which we have discussed. So prevention of SSIs emphasize the importance of good patient preparation, aseptic practice, antimicrobial prophylaxis, and attention to good surgical care. Thank you for listening po everyone.
Talk. What more can I say? Yes.
Thank you, ma'am.
Any questions from the audience? Mikey?
I have read Dr. Comendador's question po. He was asking why was there prolonged hospital stay for the patient. The patient was actually for discharge on post-op day 3. However, her child has jaundice. Hence, she was waiting for the discharge of her baby because in our hospital, the newborns that are bedside cannot be, the mother cannot be discharged if not together with the baby po. So, kailangan namin ng discharge ni pedya bago din si mommy finally makaprocess ng papers niya. Yun lang actually yung reason bakit siya natagalan. And then on day 8, yun nakita namin na may SSI na po siya.
So do you think that that was the one of the possible reasons why the patient developed SSI because she had a prolonged stay also in the hospital?
It could be po, ma'am. Pero particularly on this patient po, she was wearing her binder. And so, wala po sila masyado venue to have it washed more frequently. So, it could have really been a source of infection. Kasi unlike if they were at home, they had two binders, they can wash it. Dito mahirap because they won't let their husbands naman take it home. Mahirap talaga dito yung patient and bantay na pakisuyo. So, it could the reason why po, ma'am.
Yeah, I agree that if the binder is dirty, it can really be a cause of SSI. And then Dr. Mikey has another follow-up question.
Maybe we could start considering MRSA na, especially if the patients are not responding to our IV antibiotics given. It means na kailangan na mag-step up. There would also be signs. We could also consider MRSA when it is found in our ano po, in our wound culture po. Kikita naman po doon. Kasi yung sensitivity ng patients and resistance nakikita.
Yes, so agree. And then also if the patient stayed for a long time in the hospital, there's also a higher risk of MRSA and other bacteria that are highly resistant. Okay. So are there any other questions? Okay, so if there are no other questions, I will not present my slides anymore because anyway, your slides are almost complete, no? Okay. So, maybe we can all make our own comments or sharing of information regarding if the patient already has an SSI and then the wound is dehisced. So what usually are the cleaning agents of choice in your hospital? Because each doctor has his or her own preference. And according to my readings, there's really no one best cleaning method, no? It depends also on the hospital, what is available, and what is the practice of that particular doctor and hospital. So for me personally, what really works well is sterile saline because it's isotonic, it is not very caustic, and it's more the mechanical cleaning, no, mechanical debridement that really cleans the wound and then helps it in the granulation. But what about you, Doctora? What is, in your experience in East Avenue Medical Center, what cleaning agent works the best? Sa mga experience mo, if you already had a previous patient with SSI?
On my experience, ma'am, I have handled one SSI before po. We used the Prontosan po, ma'am. That was really good po. We after a few days po, the wound po already dried up po.
So what is Prontosan? What is the generic name? What is it made of? Do you know what it is made of? And then what is Daikin solution? Because we also had a recent case of a deep, but this is not an SSI. It's dehiscence and Daikin solution was used, and there was good granulation and healing. There was no need to resuture. So what is Daikin solution? Do you know what it is made of? Anyone? Or who is the resident from other hospitals? Can you share what cleaning solution you use?
Ma'am, Dakin solution po, actually, it's just a dilute solution of sodium hypochlorite. However, here po, ma'am, we use the modified Dakin solution. We actually ask the patient to buy Clorox po, and then we mix it with plain NSS po, ma'am, since it becomes more affordable po.
Okay, so what is the concentration? Should you use full dose, half dose? Do you think that the stronger the Dakin solution is, the better it is, or not?
We use, ma'am, the 1:4 ratio to, ma'am, because if the solution is too strong, it's actually more harmful din po to the SSI site. Natatanggal po pati yung mga regenerating tissues natin.
Okay.
So,
So yung the purpose of really cleaning it is mechanical removal of the dead cells, the bacteria, the necrotic tissue, so that there will be good granulation. And you know that there's good granulation because the wound edge is beefy red. So Dakin solution is very affordable, but again, as you mentioned, if it is too strong, when you notice that the wound edge becomes white already, it means na it also devitalizes the tissue and there will not be good wound healing. So, dapat hindi siya mamumuti. So, some would even make a parang solution combining what do they yung magnesium sulfate and also hydrogen peroxide, right? But it should be dilute enough such that the wound edge does not turn white and is not devitalized. There are also other hospitals who use medical grade honey, but the honey should be really for the purpose of cleaning wounds. Hindi yung nabibili sa supermarket. No? It's really medical grade honey. Okay? What about in other hospitals? Have you encountered cases of surgical site infection and what worked in the cleaning of the SSI? I think there's a resident from Makati Med. Meron ba? Dr. Muñoz or Dr. Mikey, meron ba kayong share? Nagkaroon na ba kayo ng SSI? Don't be shy. O sa East lang marami. Dr. Mikey, sige nga, share mo. Magsalita ka naman. Sulcosyl ointment. O sige, 3 times a day. Okay, that's also very good. It's made of calf blood, right? So, it promotes wound healing. Okay? Meron pa? From St. Luke's, meron ba? Anybody from St. Luke's? Can you share? Or anybody else? Okay. Ito. From Makati Med, we use betadine and peroxide. Sometimes we irrigate using plain NSS. Okay. Can you share, Nina, what is the concentration of the betadine and hydrogen peroxide? Nina, can you share the concentration so that we can all learn from your experience? I-share mo na lang dun sa chat box. Okay. What about if ever you're going to resuture? Sometimes it's really a deep incisional SSI or the fascia has been disrupted that you really have to close it again, right? So what uterus, you have to trim the edges and then you have to resuture it and then bumuka rin pati fascia. It's really deep organ space SSI. What kind of suture would you use?
I think, ma'am, we should use monofilament po
Yes.
versus the braided to para decrease po yung areas where the microorganisms or bacteria can grow into po, ma'am. Kasi pag ginamit natin yung braided, there are grooves where the bacteria might attach and grow po.
No? So you can use which monofilament suture has the strongest tensile strength. Yung mga talagang very severe cases of SSI, anong ginagamit nyo?
We can use PDS, ma'am.
Yes, or other monofilament sutures such as monocryl, All right. So yung Vicryl, what is it? A monofilament or a braided?
Braided. Braided po, ma'am.
What about yung mga antibiotic-coated sutures? Do they reduce SSI?
Studies have shown, ma'am, that they have actually statistically significantly reduced din po, ma'am, the risk of SSI.
There's some studies that show that probably they can also reduce the risk of surgical site infection. Is it recommended to use chromic or plain 2O in the subcutaneous area or not? Ginagamit pa ba? Uso pa ba ang chromic or plain 2O sa subQ?
In our institution, ma'am, we will rarely use that na po, ma'am.
Yes. So talagang as much as possible, we already try to avoid using chromic or plain 2O because the tensile strength is very weak. And actually, it's a component, hindi siya synthetic no? It comes from animal, diba? Organic material, and it causes more irritation, no? Irritation and inflammation, so there's higher risk of surgical site infection. So, sa subcutaneous area, saan ang pinakamagandang area mag-suture? Just above the fascia or dun sa fat? Kasi may mga iba ang taba-taba, di ba? 4 cm yung subQ nila, ang taba. How will you close that? Which is the best technique?
Then, ma'am, in the studies that I have read po, ma'am, if the subcutaneous layer is more than 2 centimeters po, ma'am, better yet do double layer closure na lang po, ma'am.
And ang pinaka-important na area above the fascia is the tawag doon is prefascial, suprafascial yon, suprafascial layer. So just above the fascia, meron pang manipis na tissue, no, na layer just above the fascia. Yun ang kunin nyo with the, for example, the Vicryl 2O na medicated or a monofilament, no. Yung fat actually, even if you suture the fat, bibigay at bibigayan if the patient is at high risk for developing surgical site infection. Pero yung that layer of tissue just above the fascia, yon ang kunin mo. Kaya parang actually medyo 2 times mo anuhin yung fascia. Okay? All right. What else? I think what you presented, yung SSI Prevention Bundle, is very good. So I think we have to adopt that. Because in East Avenue Medical Center, it's a government hospital. We have so many patients. And sometimes we have a lot of SSI. I think we have to adopt that, no? Okay. And what I read is the best, actually what is the most recommended preoperative skin antiseptic instead of povidone iodine is a combination of chlorhexidine and alcohol, isopropyl alcohol. So considering that we have so many SSIs, I think we have to modify our preoperative skin antiseptic. Okay. Ayun lang. So, that's it. Or do you have any other comments or questions? Wala? O, sige. We now go to the quiz. Sige. Ito na ang prize. Kita nyo ba? Since wala pa tayong vaccine, sana ba ako dyan? Since we don't have a vaccine yet, and in case we will have the COVID vaccine, maybe it will be the Sinovac that is only 50% effective. We still have to use mask and all the PPE. We should not let our guard down. And this one is very good. This is a brand new 3M half face mask. Okay? So my question is, in your hospital, what steps can you do to reduce SSI rates? The most important thing that you can do to reduce SSI rates in your hospital. Isang prize lang ngayon sorry. Wala ko nakuha ang sponsor. Okay, sino tong sumagot?
That's me, ma'am. It's me.
Hand washing. Tama, correct. Hold hand washing.
Reward ko, ma'am, dahil reporter.
Sino, si El Carl ba yan?
Yes, ma'am. El Carl po, ma'am.
Okay, so do you have any other comments, questions, sharing of experiences? Yung mga sa Makati Med, St. Luke's. Sa Makati Med, very low ang aming SSI rate. Sige nga, bakit? Mikey, sino pa ba ang mga nasa from Makati Med? Share nyo, bakit tayo ang baba ng SSI rate natin? Ha? Meron kaming alcohol sa bawat sulok. Ano pa? Tapos, what else? Ayun. And meron pala akong isang comment. Itong patient na to, you stepped it down, di ba? Naka-IV antibiotic and you step down to oral antibiotic. Recommended pa ba yun? Wala namang infection.
Wala, no. Actually, ma'am, there's, based on our last lecture din po, there's no need to actually step down blood.
Pero imagine mo, from IV antibiotic, step down you to oral, but you still should develop SSI. So in other words, kahit magbigay ka ng sandamakmak na antibiotic, post-op, yung more than 24 hours after, if you have poor surgical technique, or she has uncontrolled diabetes, or improper use of antibiotic, di ba? Mag-SSI talaga siya. Or poor hygiene, as was also a cause of the possible SSI, magkaka-SSI pa rin. So in other words, yung antibiotic will not be a stopgap measure to prevent SSI. Di ba? Hindi siya kasama eh. Kung titingnan mo, di ba? Prolonging antibiotic more than 24 hours, hindi naman siya ang makaka-prevent ng SSI. Okay?
Yes,
Alright.
ma'am. Thank you, ma'am.
Si Nina. What is the comment of Nina? Ayan. Other modified Dakin solution. We can mix 910 ml NSS, 30 ml peroxide, 30 ml cane vinegar, and 30 ml Sonrox. Thank you, Nina. That's very good. Okay. So thank you very much, everyone. Have a nice dinner ahead of you. And El Carl, I'll just send you the gift. Okay?